We are back with another video on anatomy PYQs for FMGE. In this video, you get previous year questions followed by a brief explanation of the topic. Treat it like your personal mock test before the FMGE. Let's jump straight into the first question.
Question 1. A 55-year-old man is diagnosed with left testicular carcinoma. Which of the following lymph nodes is the first to be involved? Here are the options. A. Inguinal lymph nodes. B. Para-aortic lymph nodes. C. Iliac lymph nodes. D. Precaval lymph nodes. And the correct answer is option B. Para-aortic lymph nodes. Here's the explanation.
We are looking at lymphatics. See, arteries are going anterior to aorta to the gut tube. So, lymphatics of the gut tube will come in front of the aorta. So, they are coming into pre-aortic lymph nodes. Gut lymphatics will come in front of the aorta, pre-aortic lymph node. On the other hand, if you are talking about the testis or the ovaries, the arteries are anterolateral, so lymphatics will also come anterolateral to the aorta. So, they are coming pre-aortic lymph node and para-aortic lymph node. But most of the books will say only para-aortic lymph node. My point is, when somebody say seminoma, where is the lymphatics involved? Your first answer should be para-aortic lymph node, but second answer additionally is pre-aortic lymph node. So, it is para plus pre-aortic lymph node? Yes. If both of them are given, then which one should I choose first? Para-aortic. And if it is not given, then pre-aortic. And if both given, then you have to choose one of them first. There are some books which will say that gonads drain into para-aortic lymph node, but there are some books which will say pre-aortic also, like Gray's Anatomy says para and pre-aortic, Smith Urology says pre and para-aortic, Dr. Vishram Singh will say pre and para-aortic. But why should we know this? Because questions are coming. Which questions are coming? Where is the question? See, tell me the answer to this question. It is asking colon, and colon is gut tube. If colon is gut tube, then it is in the midline in front of the aorta. I think it should drain in front of the aorta. Pre-aortic? Yes, pre-aortic, fine, good. Now, tell me the answer to the next question, which is gonads, means testis ovary. Yeah, I think testis ovary is anterolateral branches. Yes. Para-aortic lymphatics. Yes. Tell me which is your first answer. Now, you have two answers. The first answer should be para-aortic because majorly books say para-aortic, but there are some books which will say pre-aortic also. So, this question has double answer. If it is double answer, you have to choose one of them, and which one will you choose? D is better than C. Why? Because majority of books will say D and some additional books will say C also. In fact, both of them are the answers.
Question 2. The nerve supply of larynx above the level of the vocal cords is by. Here are the options. A. Internal laryngeal nerve. B. Recurrent laryngeal nerve. C. Glossopharyngeal nerve. D. External laryngeal nerve. And the correct answer is option A. Internal laryngeal nerve. Here's the explanation.
You are trying to say, may it be inferior thyroid artery or may it be superior thyroid artery, both of them should be ligated as close as possible to gland due to some different reasons. Yeah, maybe the reasons are different, but both the arteries should be ligated as close as possible to gland. Inferior thyroid artery should be supplying recurrent laryngeal nerve and should have supplied parathyroid gland, then it would have come very close to the gland, then you have to ligate and then remove the thyroid gland. Be careful. This is one diagram which is telling you some other story. What is the other story? Remember, vagus nerve, yes, remember, vagus nerve is giving superior laryngeal nerve and recurrent laryngeal nerve and both sides. Now, when the vagus nerve is giving superior laryngeal nerve and recurrent laryngeal nerve both sides, left recurrent laryngeal nerve is longer and coming back to supply the larynx. You are telling the left recurrent laryngeal nerve is longer and coming back to supply. That is why it is called recurrent. Yes, that's why recurrent. So, recurrent laryngeal nerve is making a loop under arch of aorta and hooking under the ligamentum arteriosum attaching to arch of aorta. You are telling that this is left-sided laryngeal nerve here. Yeah, this is left-sided laryngeal nerve, and it is hooking under the arch of aorta, hooking under some ligamentum arteriosum there. Yes, ligamentum arteriosum, the adult remnant of the ductus arteriosus. So, ductus arteriosus, adult remnant, ligamentum arteriosum, and it is hooking under that arch of aorta, ligamentum arteriosum to go back into tracheoesophageal groove. Yes, tracheoesophageal groove, you remember. Then it has to supply the larynx muscle and vocal cord below the, it has to supply larynx mucosa below the vocal cord. So, it will supply most of the larynx muscle and the laryngeal mucosa below the vocal cord. See the difference between the left and right. Right is hooking under subclavian artery to supply the larynx. So, right recurrent laryngeal nerve is short length, stays in the neck region only. Right recurrent laryngeal nerve is short length and stays in the neck region. Do not enter the thorax. Hook under the subclavian artery in the neck region and run in the tracheoesophageal groove and supply the larynx muscle and the larynx mucosa below the vocal cord. See the difference. The left recurrent laryngeal nerve is entering thorax and coming back from the thorax, but the right remains in the neck region only. Let's draw the diagram now. So, you want to draw the same diagram? Yes. Okay, fine. You are talking about the right-sided vagus nerve now? Yes, right vagus and also the left vagus. So, you are looking at right and left vagus. What are they doing? What they are doing? They are going down and they are giving some branches to larynx. Which branches to larynx? This is the larynx. This is the vocal cord of larynx. Tell me, who is supplying the laryngeal mucosa of the larynx above the vocal cord, below the vocal cord? So, this is the right vagus going down and that is the left vagus going down, and you are talking about the vagus supplying laryngeal mucosa. Which branch will supply laryngeal mucosa above the vocal cord and which branch will supply laryngeal mucosa below the vocal cord? That is what we have to discuss now. And how will you discuss? Actually, you know, the vagus would have given branch. What? The vagus would have given the branch superior laryngeal nerve, branch of vagus, and recurrent laryngeal nerve, branch of vagus. So, on the right side, this is hooking under some artery. What is that artery? Right-sided subclavian artery. And what is it doing on the left side? See, vagus nerve is giving superior laryngeal nerve on the right side, recurrent laryngeal nerve on the right side. Right recurrent laryngeal nerve is short length and hooking under right subclavian artery, remaining in the neck region. Now, if you say it is remaining in the neck region, then who is entering the thorax region by passing thoracic outlet or inlet? Who is passing thoracic outlet or inlet? Some books say thoracic inlet, some will say outlet, because if structure enter, inlet, if structure exit, outlet, whatever. So, thoracic inlet or outlet, whatever. Neck and thorax boundary, who is entering the thorax then? The left side. Can you show the left side recurrent nerve entering thorax then? Let us see, but first you have to tell. The superior laryngeal nerve is the nerve of the fourth arch and the recurrent laryngeal nerve is the nerve of the sixth arch. So most of the larynx muscle develop in the sixth arch then. So, most of the larynx muscle supplied by recurrent laryngeal nerve except one which develop in the fourth arch. So, you are telling that the superior laryngeal nerve is a branch of the vagus nerve, is the nerve of fourth arch, yes. And recurrent laryngeal nerve, which is a branch of the vagus nerve, is the nerve of sixth arch, supplying most of the larynx muscle except one. Which one? The cricothyroid, tensor of vocal cord. If you say cricothyroid muscle, the tensor of the vocal cord, it was developing in the fourth arch, is supplied by a branch of superior laryngeal nerve, name external laryngeal nerve. Remember. So, cricothyroid muscle is the only muscle of larynx which will develop in the fourth arch. Is a tensor of vocal cord, is supplied by a branch of the superior laryngeal nerve, name external laryngeal nerve. Can we see the external laryngeal nerve now? Yes, why not? Let us see. See, superior laryngeal nerve is dividing into two now, name internal laryngeal nerve and external laryngeal nerve. So, what is this internal external laryngeal nerve doing? Actually, the external laryngeal nerve, internal laryngeal nerve are branches of superior laryngeal nerve, yes, that we can see. Now, Internal laryngeal nerve go inside the larynx and supply vocal. It is supplying the laryngeal mucosa till the upper surface of the vocal cord. So, you are telling that superior laryngeal nerve gives some internal laryngeal nerve and external laryngeal nerve. Internal laryngeal nerve going inside the larynx and external laryngeal nerve going outside the larynx. Yes. An internal laryngeal nerve which is going inside the larynx is supplying laryngeal mucosa till the upper surface of the vocal cord. Yes. Then who is supplying lower surface of vocal cord? If it's a lower surface of the vocal cord and below the vocal cord, then it will be recurrent laryngeal nerve. Recurrent laryngeal nerve? Yes. Okay. So, upper surface of vocal cord and above the vocal cord is the internal laryngeal nerve branch of the superior laryngeal nerve. Branch of vagus? Yes. And lower surface, inferior surface of vocal cord and vocal cord below the laryngeal mucosa below the vocal cord is by the recurrent laryngeal nerve? Yes. And sometime they will ask you question like, who is supplying vocal cord? Then I will say both, but there is only one answer to be given. Which one will you give? So, what is the question? Question is asking laryngeal mucosa on the vocal cord is supplied by, and you will tell both the answer internal laryngeal plus recurrent laryngeal, but you have to give only one answer. Which one will you choose? If you have to really choose between the two, then you say internal laryngeal nerves, because some books say internal laryngeal nerves supply laryngeal mucosa till the vocal cord, maybe superior surface or maybe inferior surface. That is your second choice of answer. Mean to say, see, vagus nerve gave you superior laryngeal nerve? Yes. Gave you internal laryngeal nerve? Yes. Supply the laryngeal mucosa till the vocal cord, maybe superior surface, maybe inferior surface, is written by some book. So, which one will you believe? I told you what to believe first. Upper surface, internal laryngeal, lower surface, recurrent laryngeal, and if not possible, then both the surfaces, internal laryngeal.
Question 3. A newborn had hypoplasia of the mandibles and zygomatic bones, malformed external ears, and slanted palpebral fissures. Abnormality in the development of which of the following pharyngeal arches will most likely lead to the given condition? Here are the options. A. Pharyngeal arch 1. B. Pharyngeal arch 2. C. Pharyngeal arch 3. D. Pharyngeal arch 4. And the correct answer is option A. Pharyngeal arch 1. Here's the explanation.
First arch will form mandible bone. Not only mandible bone, but it will also form the malleus bone and the incus bone, which is in the middle ear cavity. Then who is forming stapes? Actually, stapes will develop in the second arch along with the upper part of the hyoid bone, along with lesser horn of the hyoid bone.
Question 4. A patient underwent a left submandibular gland excision during which the hypoglossal nerve was injured. Which of the following deficits would be seen in this case? Here are the options. A. Deviated tongue to the contralateral side. B. Deviated tongue to the same side. C. Inability to protrude the tongue. D. Loss of taste in the posterior 1/3 road of the tongue. And the correct answer is option B. Deviated tongue to the same side. Here's the explanation.
What about genoglossus? What is genoglossus? If you remember, we have discussed one thing. Lateral pterygoid will aim the tongue. What is aim the tongue? Lateral pterygoid will aim the mandible. The lateral pterygoid will aim the mandible. What is that? Taking the mandible anterior and inferior and medial, and both the lateral pterygoid can cancel each other. If the right lateral pterygoid is not working, then the left becomes more powerful and pull the mandible towards the same side of the lesion. Similarly, remember, genoglossus muscle is the muscle of tongue. It will aim the tongue. Means it will take the tongue anterior and inferior and medial. Yes. As the lateral pterygoid will aim the mandible, and if the right muscle is not working, mandible deviate to right side. Similarly, genoglossus muscle, you see, it is taking the tongue anterior and medial also and inferior also. You are telling that it will protrude the tongue in the midline? Yes, if both are working. If both of them are working, then they protrude the tongue in the midline and depress the tongue also. Genoglossus. And what if one of them is not working? Which one? The right-sided. So now you're telling that right genioglossus is not working, right hypoglossal nerve injury? Yes. Then they cannot balance each other and there will not be a net protrusion in the midline. Then what will happen? If the right genioglossus is not working, then the left is more powerful. Keep pulling tongue to midline, midline, midline and cross the midline and tongue will deviate to the same side of lesion. See? The left genioglossus became more powerful, and when the left genioglossus became more powerful, cannot be balanced by the right side, he'll keep pulling tongue to midline and then tongue will deviate to the same side of lesion.
Question 5. A patient with leprosy presented with the deformity as shown below. Which nerve injury causes the given condition? Here are the options. A. Ulnar nerve. B. Radial nerve. C. Median nerve. D. Posterior interosseous nerve. And the correct answer is option A, ulnar nerve. Here's the explanation.
In ulnar nerve injury, the lumbricals which belong to the ring finger and the little fingers will be compromised. Since it is understood that the lumbricals for these fingers are under ulnar nerve. There are 4 lumbricals. These 2 lumbricals are still working because they are being supplied by median nerve. The problem is with the medial 2 lumbricals. And hence you can see now the interphalangeal joints are going into flexion deformity. And why the interphalangeal joints are in flexion deformity? Because of the unopposed flexor digitorum muscle. Normally the lumbricals are balancing the anterior forearm muscles. And if lumbricals are not working, the anterior forearm muscles, the flexor digitorum muscles become more powerful and they can bring the fingers into flexion deformity. Then why we are having MCP extension? The MCP extension occurs because of the unopposed extensor digitorum muscle. Again, the logic is normally extensor digitorum muscles in the posterior forearm are being balanced by the lumbricals. And if lumbricals are not working, the extensor muscles of the posterior forearm become more powerful, bringing MCP joint into hyperextension. It is quite evident that if the lumbricals are not working, MCP joint cannot flex, interphalangeal joint cannot extend. And the anterior forearm muscles, they bring the interphalangeal joint into flexion deformity, whereas the posterior forearm muscles, they bring the MCP joint into hyperextension, especially more so towards the medial 2 fingers, lumbricals being supplied by the ulnar nerve.
Question 6. Identify the tarsal bone labeled in the image below. Here are the options. A. Calcaneus. B. Cuboid. C. Navicular. D. Talus. And the correct answer is option C, navicular. Here's the explanation.
The first one is the heel bone, the calcaneum, which you can demarcate here. And on the calcaneum bone, you can see there is the talus bone. And when you are talking about the tarsal bones, laterally you'll find the cuboid bone. And if you're talking about the medial side, the navicular. So here, laterally is cuboid, which will be contributing to lateral longitudinal arch. And medially is the navicular, which is going to contribute to the medial longitudinal arch.
Question 7. All of the following are paired cartilages except? Here are the options. A. Arytenoid. B. Thyroid. C. Cuneiform. D. Corniculate. And the correct answer is option B, thyroid. Here's the explanation.
What about the 3 paired cartilages? You can see them from the posterior view of the larynx. And when you see the posterior of larynx, I see 3 paired cartilages. Who are they? Let us name them. They are a pair of arytenoid cartilage, and on that, a pair of corniculate cartilage, on that, a pair of the cuneiform cartilages.
Question 8. Which of the following muscles is an abductor of the vocal cord? Here are the options. A. Lateral cricoretinoid. B. Posterior cricoretinoid. C. Thyroarytenoid. D. Vocalis. And the correct answer is option B, posterior cricoretinoid. Here's the explanation.
Posterior cricoretinoid muscle. Why would you say posterior cricoretinoid? Because attaching the cricoid cartilage and the arytenoid cartilage. So you are telling that there is some muscle on the posterior side of larynx. Yes. Attaching this cricoid cartilage with arytenoid cartilage. Yes. What is it doing? This is the safety muscle of larynx. Why would you say this is safety muscle of larynx? I will say this is safety muscle of larynx because this is the only abductor of the vocal cord. It will help us to breathe by opening vocal cord. So help us to breathe opening vocal cord. What if it is paralyzed? If it is paralyzed, then you will have difficulty breathing because vocal cord will be closed.
Question 9. Identify the muscle marked in the IAM. Here are the options. A. Flexor carpi radialis. B. Flexor carpi ulnaris. C. Palmaris longus. D. Median nerve. And the correct answer is option A. Flexor carpi radialis. Here's the explanation.
The muscle is taking origin from common flexor origin and then it is coming down towards the wrist joint, inserting on the basis of the metacarpals towards the radial side. Hence the name is flexor carpus radialis. As is evident here, not only it is going to flex the carpus region, but it can also take the carpus towards the radial side. That is called as the radial deviation or ABD, abduction.
Question 10. A patient has lost sensation over the dorsum of the foot and medial foretoes. There is the associated difficulty of eversion of the foot. Which nerve injury is likely to be the reason for this? Here are the options. A. Deep peroneal nerve. B. Superficial peroneal nerve. C. Common peroneal nerve. D. Posterior tibial nerve. And the correct answer is option B. Superficial peroneal nerve. Here's the explanation.
Anterior leg compartment, you have anterior tibial nerve, and that anterior tibial nerve is also called as the deep peroneal nerve. Actually, we have got a common peroneal nerve dividing to superficial deep branch. So deep branch, which is deep peroneal nerve, works as the nerve of extension, whereas superficial peroneal nerve, branch of the common peroneal nerve, works for the foot eversion.
Question 11. Deep inguinal ring is a defect in. Here are the options. A. External oblique aponeurosis. B. Internal oblique aponeurosis. C. Fascia transversalis. D. Rectus sheath. And the correct option is C. Fascia transversalis. Here's the explanation.
That is the transversalis fascia. Can you see a defect in the transversalis fascia? That defect in the transversalis fascia, deep to transverse abdominis muscle, is a deep inguinal ring. So deep inguinal ring is a defect in the transversalis fascia for what? To let the testis come. And now what is coming? The spermatic cord is coming into the inguinal canal.
Question 12. A newborn presented to the NICU with respiratory distress and meconium discharge from the umbilicus. The condition occurs due to the patency of which structure? Here are the options. A. Mesonephric duct. B. Allantois. C. Uricus. D. Vitellointestinal duct. And the correct option is D. Vitellointestinal duct. Here's the explanation.
The vitellointestinal duct is a midgut diverticulum, whereas the allantois is the hindgut diverticulum, and both of them are content of the umbilical cord. Normally, they should be obliterated, because if they are not obliterated, there can be problems. A baby born with the fecal matter at the umbilicus, and it is called as Meckel's fistula. A baby born with urine at the umbilicus, and it is called urachal fistula. So, if the allantois is not obliterated properly, then there can be urachal fistula bringing urine to the umbilicus of a newborn baby. And if vitellointestinal duct is not obliterated properly, then bring the fecal matter to the umbilicus, could be Meckel fistula.
Question 13. The marked muscle is supplied by which nerve? Here are the options. A. Radial nerve. B. Ulnar nerve. C. Median nerve. D. Musculocutaneous nerve. And the correct option is D. Musculocutaneous nerve. Here's the explanation.
And it is the lateral cordobrachial plexus, which will continue as the musculocutaneous nerve, which after supplying 3 muscles in the anterior arm will be continuing as a cutaneous branch to supply skin on the lateral aspect of the forearm, the lateral cutaneous nerve of forearm. Hence the name is musculocutaneous nerve. The same details can be seen in a magnified view here, showing the 3 cords of brachial plexus in the axilla, lateral, posterior and medial. And it is the lateral cord which then continues as the musculocutaneous nerve to supply the 3 muscles in the arm region before it becomes a cutaneous branch. So, which 3 muscles? We have learned that there is a muscle coming from coracoid process to the brachium, the coracobrachialis, and then it is supplying the biceps brachii, may it be the short head or the long head, and it also takes care of the brachialis muscle then. The root value of muscular cutaneous nerve is C567, and as we have discussed, if there is a lesion like Erb's palsy where C5-6 are compromised, C7 was still working, and that is where we mentioned since the coracobrachialis muscle has all the three root values C5-6-7, it may not be paralyzed in Erb's palsy. But since the C5-6 is the major root value for biceps brachii as well as brachialis, both were compromised to a greater level and leading to difficulty in elbow flexion. Not only elbow flexion but also difficulty in supination, because biceps brachii is a powerful supinator. That is why in Erb's palsy, policeman tip hand deformity, elbow cannot flex, remains in extension, and cannot do supination, so remains in prone posture. If you remember policeman tip hand deformity, partial injury of muscular cutaneous nerve. And now we want to look at some more details of this biceps brachii muscle in the next diagram. As the name is suggesting, the muscle has two heads and is present in the arm region, biceps brachii. The short head takes its origin from the tip of coracoid process along with the coracobrachialis muscle, whereas the long head is, if you remember, having intracapsular origin, which happens quite rarely, from the supraclinoid tubercle of the bone scapula.
Question 14. A patient presented to the OPD with an abnormal gait. On examination, when the patient was asked to stand on the left foot, a right-sided hip drop was observed. Which of the following muscles are paralyzed in this patient? Here are the options. A. Right gluteus maximus and gluteus medius. B. Right gluteus medius and gluteus minimus. C. Left gluteus maximus and gluteus medius. D. Left gluteus medius and gluteus minimus. And the correct option is D. Left gluteus medius and gluteus minimus. Here's the explanation.
Now we will be talking about the third action of the trio muscle. Trio muscles are gluteus medius, gluteus minimus, and the tensor fasciae lata. And they'll be doing hip abduction, medial rotation, and pelvic stabilization, especially important when we are walking. So, what about that pelvic stabilization? This is the description. When we are walking, we will take one foot in the air, and that will be the swing phase of walking cycle. At that moment, the other foot will be fixed to the ground, and that is the stance phase. Now, since you have taken the foot off the ground, obviously gravity will pull this sided pelvis down. That means the left pelvis has a tendency to fall down because the gravity pulls it down. So, how are you going to prevent that pelvic tilt downwards? For that purpose, these trio muscles, they have the function of pelvic stabilization. At this moment, the origin insertion will interchange. See, one thing is clear. Since you have fixed the foot on the ground, obviously you cannot move the femur now. So what will move? The hip bone will be moving. The origin becomes insertion and vice versa. So what is this trio muscle doing then? They will be pulling the right pelvis down. And what will happen if you pull the right hip bone down? See, pelvis is a single unit. If you're pulling it from one side, automatically the other side will go up. It is like this. There will be a pelvic tilt. Then means they are creating a vector which will pull the pelvis on the other side upward. This is called pelvic rotation. So, trio muscle of the right side will pull the right hip bone down, and automatically the left hip bone will go up. It will be basically a purpose to counteract the gravity here. The gravity was pulling the left pelvis down. You have to balance it, and you are creating a vector which will be balancing it. But that vector is created from the opposite-sided trio muscles supplied by superior gluteal nerve. What will happen if I have superior gluteal nerve injury on the right side? If you have superior gluteal nerve injury on the right side, trio muscles will not pull the right pelvis down, and the left pelvis will not go up. That vector is missing. So then gravity become more powerful. It will pull the left pelvis down. down, Trendelenburg test will become positive. The patient will have to drag the foot on the ground. You cannot elevate it because limb length has become more. So during the course of disease, this patient will learn to walk with a lurching gait.
Question 12. Failure of closure of rostral neuropore at 25th day leads to? Here are the options. A. Hydranencephaly. B. Rachis. C. Anencephaly. D. Spina bifida. And the correct option is C. Anencephaly. Here's the explanation.
In this diagram, as we continue looking at the dorsum of the baby, from the ectoderm, neuroectoderm develops a plate which is called as the neural plate. And as it is understood, this plate is now folding and forming a neural groove. And then there occurs a fusion in the cervical region, and we find that neural tube formation has now begun. There comes a question asking where the neural tube formation begins. You say in the neck region, cervical region, and then there'll be a zipping up and zipping down of the fusion, cranially and caudally, which is also called as anterior and posterior in this stage of development. So as you see, the neural tube has now formed, but it is having some opening on the anterior or cranial side, the anterior or cranial neuropore, and one opening which is on the posterior side or the caudal side, the posterior or caudal neuropore. And these pores must close, because if they are open, then we may have what is called as open neural tube defects. Non-closure of anterior neuropore resulting in anencephaly, and non-closure of posterior neuropore resulting in rachis. So when exactly are they closing? The anterior neuropore is closing at day number 25 of development, and posterior will close after 3 days, day number 28. We'll be drawing similar diagram and discussing the neural tube defects as well. But here you can notice one more thing, that it was the mesoderm, the paraaxial mesoderm, which is going to form the somites. And these somites, they are going to contribute to the vertebra formation. As we understand, half vertebra develops on one side and half on the other side. And then this mesodermal tissue will be enclosing the neural tube, which is shown in blue color here. The orange color is the mesoderm. And then what is the layer which will cover most superficially? That will be the ectoderm, surface ectoderm, forming the skin epithelium. As we understand, we have learnt outermost layer is skin epithelium coming from surface ectoderm. If you remove it, you'll find the mesoderm forming the vertebra, and if you remove that, you'll find the neural tissue coming from neuroectoderm. Now let us draw these diagrams ourselves as well and discuss some more details of neural tube defects. And here we draw the head of the baby and the body of the baby. We are looking from the dorsum of the baby, and we found that there was a plate that is called as the neural plate coming from the neural ectoderm. And later there will be formation of the neural fold, neural groove, and the fusion begins in the cervical region, and then occurs the formation of neural tube. There will be a zipping up and zipping down, and a tube will be formed. There will be one anterior or cranial neuropore, and then we have posterior or caudal neuropore. So we can mention the detail. This is the anterior or cranial neuropore, which must be closing in due time so that the brain can form. And similarly, we have got the posterior or caudal neuropore, which must be closing, and spinal cord will form properly. So when are they closing? We already have mentioned if it is the anterior or cranial neuropore, it must be closing by day number 25 of the development. And the posterior neuropore has to close after 3 days. That is day number 28. And if they are not closing, there can be open neural tube defects. Now you are suspecting a case of open neural tube defect, and there may be a problem with the formation of the brain, or there could be a problem with the formation of the spinal cord. Actually, what you have found is there were high levels of alpha-fetoprotein in the maternal serum. And once you found that there are high levels of alpha-fetoprotein, you checked for an enzyme, and even there were raised levels of acetylcholine esterase enzyme. In such a scenario, you are doing ultrasound, and you may find cases of open neural tube defect called as anencephaly or rachis. So as we mentioned them here, number 1, it could be a case of an encephaly, or number 2, it could be a case of rachis. So how do you define them? See, what happens is, if there is non-closure of the anterior neuropore, the brain will not develop properly. There will be a small brain. So you can mention the details here. Anencephaly occurs due to the non-closure of anterior neuropore, resulting in small brain, and it is actually exposed outside. And why is it exposed outside? Because the covering cranial vault is not formed properly. There is a skull defect. So cranial vault is missing and leading to degeneration of the brain. And why there is degeneration of the brain? The brain is degenerated because it is exposed to the amniotic fluid. As the skull is missing, the brain is exposed to the amniotic fluid. Plus, these babies are not having the swallow reflex. The urine is being formed, but the baby is not drinking the urine. And that is why mother will have more of amniotic fluid, what is called as polyhydramnios.
Question 16. Kilian dehiscence is present in? Here are the options. A. Superior constrictor muscle. B. Inferior constrictor muscle. C. Middle constrictor muscle. D. Esophageal fibers. And the correct option is B. Inferior constrictor muscle. Here's the explanation.
There is a superior pharyngeal constrictor, and there is a middle pharyngeal constrictor, and there is a inferior pharyngeal constrictor. Inferior pharyngeal constrictor is having two parts, and we will be talking about two parts because there is sometime a deficiency which is called Kilian's dehiscence, and through the Kilian's dehiscence some pouch will come, and there is some Zenker's diverticulum. What is that? Zenker's diverticulum pharyngeal pouch. Oh, you are telling inferior constrictor has two parts, there is some deficiency between the two parts? Yes, we have to talk about, because that Kilian's dehiscence, some Zenker's diverticulum can come.
Question 17. Mediastinal surface of the right lung related to? Here are the options. A. The azygos vein. B. The right lymphatic duct. C. The aorta. D. The trachea. And the correct option is A. The azygos vein. Here's the explanation.
You will see that there is azygous venous system which we need to discuss actually. There is this azygous vein which is on the right side, and then there is hemiazygous vein which are 2 in number on the left side. Now this left-sided azygous veins, hemiazygous veins, they drain into azygous vein, and azygous vein will drain to superior vena cava. There is one a hemiazygous vein which is draining the lower intercostal spaces, and then there is accessory hemiazygous vein which is draining the upper intercostal spaces. This accessory hemiazygous vein and the azygous vein, they cross the midline in the vicinity of T8 vertebra and then drain into the azygous vein, and then azygous vein will drain into the superior vena cava at the vertebra number T4. This is the description.
Question 18. Retraction of the scapula at the sternoclavicular joint is done by? Here are the options. A. Serratus anterior. B. Trapezius. C. Subscapularis. D. Supraspinatus. And the correct option is B. Trapezius. Here's the explanation.
We need to know the 3 set of fibers and their respective attachment, because that will tell us about the different action of the trapezius muscle. And as is evident, this muscle is triangular in shape. If you combine the 2 triangular muscles, then it will become trapezium shaped, and that is why the name trapezium. But unilaterally it is triangular in appearance. Talking about its nerve supply, trapezius muscle is supplied by spinal accessory nerve, and we would like to know what will happen if this nerve is lesioned. But first, we must know what are the actions this muscle is supposed to do. Now, since there are different set of fibers inserting like a J-shaped fashion, we find the upper fibers of the trapezius muscle are going to elevate the clavicle bone, scapula bone, or the shoulder joint. Elevation at the shoulder joint, shrugging of the shoulder. And how do you explain the depression then? It will be the inferior fibers of the trapezius, as we have seen. They can pull the scapula downward. Hence, depression can be explained. And what about the middle fibers? Middle fibers, they can pull the scapula towards the midline, what is called as the retraction of the scapula. As we have seen, it is working along with the muscles like rhomboid major and minor. So here you see the trapezius is helping in retracting the scapula. Then we have to talk about the trapezius working with serratus anterior for overhead abduction more than 90 degree. So how does it work with serratus? It will be taking the glenoid cavity superiorly. As we know, the glenoid cavity normally is directed laterally. This is the glenoid cavity of the bone scapula here, and if we want the humerus bone, which is articulating here to make the shoulder joint, to move beyond 90 degree of abduction, then this glenoid cavity must be facing upwards. So which kind of rotation do you require to take the glenoid cavity upwards? As we remember, along with serratus, it will be causing lateral rotation of scapula. And for this lateral rotation of scapula, which will rotate the scapula outside, and the glenoid cavity will now face superiorly, taking the humerus bone along with that for more than 90 degree of abduction. The fibers working for this movement are upper fibers of trapezius and lower fibers of trapezius. They are working in synchronization and rotating the scapula lateral for overhead abduction by turning the glenoid cavity superior.
Question 19. Which of the following structures passes through Guans Canal? Here are the options. A. Flexocarpi radialis. B. Radial nerve. C. Ulnar nerve. D. Median nerve. And the correct option is C. Ulnar nerve. Here's the explanation.
Then what about the 1.5 fingers and the ulnar side of the palm? That cutaneous supply is from the ulnar nerve. As you follow the ulnar nerve, it is moving along with the ulnar artery, passing superficial to flexor retinaculum. But before it reaches the level of flexor retinaculum, it gives a cutaneous branch, the palmar cutaneous branch, and this is the one which is going to supply the skin on the palm towards the ulnar side. Then the ulnar nerve is going superficial to flexor retinaculum, passing into a tunnel which is called ulnar tunnel, or the other name is Guans Canal. And in the Guans Canal, the ulnar nerve will be giving two branches, one superficial and one deep. The superficial branch will be going towards the skin of the 1.5 fingers, the cutaneous supply, whereas the deep branch is going to supply the hand muscles, like the 4 palmar interossei, 4 dorsal interossei. But be careful, the ulnar nerve is passing superficial to flexor retinaculum. So officially only there is a structure called as the ulnar tunnel or Guans Canal. If it is compromised there, then there will be sensory loss on the skin of 1.5 fingers, and the hand muscles also get compromised.
Question 20. Pointing index finger is seen in which nerve injury? Here are the options. A. Axillary. B. Radial. C. Median. D. Ulnar. And the correct option is C. Median. Here's the explanation.
You must have observed when we are in the church, the priest will be giving his blessings, and he has got a typical gesture of his hand. Derived from there only, this hand of benediction term has come in the literature. Here you have to ask the patient to make a fist. And when the patient is making a fist, what you find is the patient is able to fold these 2 medial fingers properly, but the 3 lateral fingers, they are finding difficulty in flexion. And if the patient tries, there will be slight flexion, but not the complete movement. And then it appears like the hand of benediction. In these 3 fingers, specifically the index finger will find difficulty in flexion. There is one test also for that, which is called as the pointing index finger. But what exactly is the problem here? This happens in median nerve injuries at a higher level, say for example supracondylar fracture, leading to weakness of some of the muscles, especially the muscles supplied by a deep branch of the median nerve, anterior interosseous nerve in the anterior forearm. We understand that there is a muscle, flexor digitorum profundus, for folding the 4 digits here. And these 2 fingers can be folded by the medial half of flexor digitorum profundus, as it is supplied by ulnar nerve. Since the ulnar nerve is working properly, these 2 fingers find no difficulty in flexion. But when it comes to flexion of these fingers, it is to be done by the lateral half of the flexor digitorum profundus. Being a deep muscle of the anterior forearm, it is supplied by anterior interosseous nerve, branch of the median nerve. If the median nerve is compromised, these fingers find difficulty in flexion, especially the index finger is more severely affected. Even the muscle flexor pollicis longus supplied by anterior interosseous nerve is compromised. and finding difficulty in flexion of the thumb. So basically these three fingers find difficulty in folding, giving the appearance of hand of benediction.
Hope you gained some insight out of the video. Join us tomorrow for part 2 of anatomy from FMGE Recall Run. Let us know your feedback in the comments and dropping a quick like. Join the PrepLadder community by subscribing if you are new here. See you soon.